Namaste everyone. Thank you so much for joining us today and welcome to the 27th webinar of Nepal Mental Health Research webinar series. I am Binita Achari, working as a research officer at TPO Nepal, moderating this webinar like most of the time. And before moving forward to the webinar, I would like to introduce our team for today as well. We have Ritika Singh, who is a research consultant at George Washington University for technical support and assistance. And we also have Jisri Guru, who is project lead at TPO Nepal and PhD candidate at King's College London. She will be introducing our speaker for our webinar series for today. So if you are joining for the first time, these webinar series are being conducted by TPO Nepal in coordination with George Washington University, focusing on the capacity building of early and mid-career mental and behavioral health researchers. So as you can see in the screen, the title of our 27th webinar, which is Evaluating Interventions and Programs in Mental Health Research, what you need to know about the cluster randomized trial design. And our speaker for today is Dr. Elizabeth Turner. We also call her Liz. And our Jisri Gurung will be introducing our speaker after some minutes. So before that, we have some couple of reminders which we share in our each webinar. So first thing first, letting you know that we do record our webinar, which has been already started. So basically, the main motive of recording this webinar is that we do share our webinar recordings to the registered participants. Also, we do upload the recording in our TPO Nepal YouTube channel as well. So to remind you, if you want to access the webinar materials, please do register the webinar, which you can find the form in our social media pages as well. So the next reminder is related to the webinar structure. So basically, the duration of our webinar is an hour, 6 to 7 p.m. Nepal time. And after this introductory session and background information about the webinar, there will be the 30 minutes of time duration for the presentation of our speaker. So to remind you and to update you, so we have expanded the duration of the presentation, speaker's presentation from 15 minutes to 30 minutes. And we have excluded the breakout session to make it more comfortable for the audiences and for the early career researchers to discuss and not to make them feel pressurized in the webinar as well. So the last reminder is, of course, related to the feedback form. So if you have any kind of suggestions related to the topic or related to the structures or what you want to hear from the speaker or any kind of feedbacks you want to share, we would appreciate your feedback. So please do fill out the feedback form. We will share this feedback form with the webinar materials. Also, we will keep that in the message box as well later after the webinar. Just the background information, these monthly webinars are being conducted on the third week of every month. Invitation emails will be sent out with dates and speaker details and for further informations and update. You can follow us in our social media pages. Or in addition, if you need any further information related to our MHRN network, you can directly email us to our email address, of course. So for now, for the introduction of our speaker today, I would like to request Jisri Guru to go ahead. Thank you.
All right, thank you so much, Bintaji, and hello, everyone. It is my pleasure to introduce to you all today our speaker for the 27th webinar. So as Bintaji mentioned, our speaker is Dr. Liz Turner, who is a biostatistician with more than 20 years experience in public health research. She is an expert in the design and analysis of global health trials, including cluster randomized trials, stepwise trials, and implementation trials that we will be hearing about today. Liz has served as statistical team lead for more than 20 global health trials, primarily in the substantive areas of mental health, malaria, and cardiovascular diseases. She currently serves on the faculty at Duke University as Associate Professor of Biostatistics and Global Health, as co-lead of the Biostatistics and Study Design Working Group of the NIH Pragmatic Trials Collaboratory, and since its creation 12 years ago as director of the 10-member Research Design and Analysis Core of the Duke Global Health Institution. Yes, and so without further ado, I will now pass it on to Liz.
Thank you so much, Drishti, Binita, and Ritika, and namaste, everybody. I'm so happy to be here. And thank you so much for the really kind introduction as well, and the opportunity to just share a big passion and love of mine, which is designing global health trials, and particularly using the cluster randomized trial design. So I'm going to share my screen, and if ever there is an issue with the sound or the image, please don't hesitate to let me know. And I think I'm going to minimize the window here in a moment so that it's easier for me to see my own slides as well. So we'll get going for the next 30 minutes. So evaluating interventions and programs in mental health research and what you need to know about the cluster randomized trial design. So I'm going to end with this slide as well. So I know it's evening for you. Maybe you're making your dinner and you're with your families perhaps, and you have lots of things going on. So these are the key things really that you need to know. So if you haven't heard about these designs before, they're really quite useful designs. So they're a randomized trial design, but we do not randomize individual people. I'll show you images of this later, but groups or clusters of individuals are randomized. And we often use this to evaluate the effectiveness and implementation measures of group-based and facility-based interventions. Here we go. So the challenge then is that because we have this clustered design, we randomize groups of individuals, we have clustering of outcomes. And I'm going to show you visually what that means a little later. And then in turn, this means that we have a lower effective sample size than we would have if we did a standard individually randomized controlled trial, were we to have the same number of participants in the cluster randomized trial. So effectively, we actually kind of seem to have a smaller trial, even if we have the same number of people. So a smaller trial when we have clustering of outcomes in a cluster randomized trial. All this I will show to you in visuals later on. So this outcome clustering, so maybe of a mental health measure of the outcome of interest in a trial, again, I'll show you that in an example, it must be accounted for in the design and analysis using special statistical methods. And in addition, there's many, many different kinds of cluster randomized trial design. So CRT design, that's the cluster randomized trial design that are available. But because of this penalty you pay of having a lower effective sample size in cluster randomized trials, we still recommend, if it's possible to perform a regular randomized controlled trial, so RCT, it's preferable to do that than a cluster randomized trial. But what I'm going to go through today is that there's many situations where we can't perform a regular randomized controlled trial, and that cluster randomized trial design is the best design. So we'll go through this in 4 parts. I'll talk about the Group Problem Management Plus cluster randomized trial that took place in Morang in Nepal. I'll talk more about this clustering of outcomes, so a little primer with 3 slides of visuals, the fundamentals of cluster randomized trial analysis and how that must account for clustering of outcomes. So those second and third section are very much related. And then zooming back to the fundamentals of cluster randomized trial design and different types of possible designs. I'll just talk about a few of those and certainly not all of the ones that could be considered. So, excuse me. I'll talk about this paper that was published in PLOS Medicine on effectiveness of the Group Problem Management Plus intervention, this brief psychological intervention. So this was conducted, first of all, let me talk about the intervention itself. So this psychological treatment has 5 weekly group sessions led by non-specialists, and those groups are conducted in single gender groups, so men separately from women, groups of about 8 to 10 people. And the outcomes in this trial, the primary outcome was psychological distress assessed by the General Health Questionnaire. And then we had secondary outcomes, a range of those, and they included heart-mind problems, depression symptoms, post-traumatic stress disorder, social support. And we measured the individuals at baseline, at 7 weeks after baseline, and 20 weeks after baseline. And we named those midline and endline. It was conducted, as I mentioned, in Morang district in November, so in Western calendar in November 2018 to September 2019. And the eligible participants were adult men and women who were screened and positively for psychological distress and functional impairment. And I won't go into the details of the measures we used there. So in practice, we had over 600 participants across 72 wards, and those wards were the clusters. And I'm using my hands, but we'll show you visually in a moment. So about 8 to 10 participants per ward. It did vary between the wards. And those 72 wards those wards themselves, those clusters, were randomized so that 36 were in intervention and 36 in usual care. And then the participants received the services based on their ward, so the allocation of their ward, i.e. of their cluster. So if they were in the intervention ward, the participant had access to group PM+. And we ran one group in each ward that was randomized to group PM+. So here we have, I'm showing these sort of little shaped sort of curvy squares, 72 wards. And what did we do? Well, we randomized them. Oops, here we go. Sorry, it's clicking a little fast here. We randomized them. Hopefully you can see my cursor, so that half of them, 36, were randomized to receive, the members to receive group PM+, and half to receive enhanced usual care. So the randomization took place first, and later we recruited the participants. So suppose this ward right here, this one had been randomized to group PM+. So we then enrolled, in this instance, I've shown 8 participants. We targeted between 8 and 10 participants in that ward, and then they would all be eligible to go to the group that was being offered, the group PM+, the 5 sessions led by the non-specialists within that ward. So this is a very particular kind of cluster randomized trial design. We randomize the clusters, the wards first, and then recruit the participants afterwards. So what I do want to note is, within the ward, there are many more people than 8 people, but we, into the study itself, recruited only 8 to 10 per ward. So there we go, ward randomized to enhance usual care. In this example too, I've shown 8 participants were then enrolled within that ward. And then here we see an example where there's exactly 8 participants in each of the 72 wards. And the outcomes, as I mentioned, were measured at baseline, 7 weeks after baseline, and 20 weeks after baseline. So we've randomized these wards, these clusters. So here now I'm showing people up here, just as a visual representation of individuals. And we know we're going to randomize them to receive the intervention or not. And we hope the intervention will have an impact and reduce, on average, we'd have lower psychological distress in individuals who are in intervention wards, so group PM+ wards, compared to those in the enhanced usual care wards that are considered our control wards. And I won't say much more now about the enhanced usual care. We'll just keep talking about intervention versus control. And so what you see here is I'm trying to represent that these individuals are nested within the wards, within these wards, which are our clusters. We also know that there are other factors that can drive psychological distress, like, for example, age or other external factors that are going on. But our hope is that by randomizing these wards to receive either the group PM+ intervention or the control, the enhanced usual care, that we can break the link that we may expect to be exist between individuals who receive group PM+ and those factors related to psychological distress. So this is the same flavor of why we do any kind of randomized control trial. It's to try to break this kind of link so that we have no confounding of when we try to assess the intervention impact on our outcomes of interest. And it so happens that because we have a lot of wards, so these 72 clusters, and we use a special kind of randomization strategy called constrained randomization, I won't talk about the details, that it should be a reasonable assumption that we've broken this link here. And if we see any difference in outcomes between the group PM+ arm, the intervention arm, and the control arm, that we would expect that to be as a result of the group PM+ intervention. Now, I do want to make a warning here for those of you who may then hope to kind of conduct these trials in future, or you evaluate them when others have conducted them, that many cluster randomized trials have maybe 30 or fewer clusters. So imagine 30 wards. So we have to be very careful about how we perform this randomization procedure. So we really can try to break this link here so that we really can attribute any beneficial effects to the intervention. So just in summary, we did note a beneficial effect of the intervention on psychological distress. It was primarily driven by an effect in women. I'm not going to talk about the male-female differences in this talk today. And we had an a priori hypothesis it would be mediated by use of the specific skills taught in group PM+, and then our analyses showed that there was evidence of that. So we had evidence of benefit throughout. In addition, we not only have these individual outcomes nested within the wards, those clusters, we have outcomes themselves nested within the individual because we have 2 follow-up time points. So that's another feature we would have to account for in statistical inference. Okay, so as we wrap up this portion on the motivating example, I wanted to let you know that we had 4 key publications related to the trials and to show you the arc of this kind of research. So we worked on a feasibility study, first of all. We published, so we had the protocol, we published the outcomes of that feasibility trial that helped really set up procedures and understand context. And then we also published the protocol for the trial, the large scale 72 cluster trial I talked about here. And then, as I mentioned earlier, published the outcomes. And what was really exciting, so all of this has been in partnership with TPO Nepal, and I've had a very long-standing collaboration with the organization, which I really cherish immensely. And in addition, our evidence was able to inform practice. So the WHO has developed a manual now, a protocol for conducting group problem management plus, so group PM plus in practice, and it's available in multiple languages and has been available since 2020. So really a success story of how the evidence from a cluster randomized trial has been able to inform practice and policy at a very high level. Okay, so let's switch now to clustering of outcomes, just 3 slides here. So I mentioned this clustering, the individuals nested in the clusters. So first of all, let's imagine there's no randomization has taken place. Let's just do a thought experiment. We have 10 control arm wards. So these are the wards that are receiving enhanced usual care. And just for ease of visualization, let's imagine there are 5 eligible participants. So not 8, not 10. And let's also just think now, instead of talking about a scale of psychological distress, we'll say, does someone have psychological distress at the 20-week follow-up? Yes or no? So that Y/N is yes or no. Okay, so this is a situation where there is complete clustering. What do I mean by that? So you see that there are 10 wards here, so the 10 larger circles. And in each of those circles, remember, there's no intervention here. We're just in kind of observing people. And what we see is these red dots, for example, here, everybody would be considered not distressed, at the 20-week follow-up. Whereas in contrast here, over here, the purple ones, these are considered to be distressed at the 20-week follow-up. So we have 4 wards, 4 clusters where, and sorry, this is 20-week follow-up, having followed in, did I say, yeah, a 20-week follow-up, but in the absence of an intervention. So let me just clarify that. So not comparing intervention to control, we're just observing people over time. So we have 4 clusters in purple where everybody is distressed, and 6 clusters in these red dots where all 5 people in the clusters are not distressed. So we see there's no variability within the cluster, but there are differences between some of the clusters. And in this case, the effective sample size is just 10, like 10 wards, because once you observe one individual in a ward, everybody else has exactly the same outcome. So this is a notion of complete clustering. The effective sample size is 10, not 50, which would be 10 times 5, the 50 dots we see on the screen, the small dots. Now here there's some clustering. You see there's still some, in most clusters, there's still some, now there is some within cluster variability. There's some reds, there's some purples, there's some distressed, some not distressed. And there's some between cluster variability as well. There are different proportions who are distressed, so different fractions that are purple. So here there's 1 out of 5 is distressed. Over here, there are 2 out of 5 who are distressed. So in this case, the effective sample size is somewhere, I'll have a little typo here, is between the 10 clusters and the 50 people in total. So the effective size is between 10 and 50 because we have 10 times 5 people making a total of 50. Sorry about that, this 100 should say 50 here. And then here, a situation with no clustering. So what you see is there's exactly 1 purple, so 1 out of 5 people in each of those 10 clusters. So each of the 10 wards is distressed here. So we do have some between cluster variability. There is some within cluster variability, but there's no structure according to the wards because every single ward looks the same as each other. So here, the effective sample size, sorry, that should say 50. There's 5 people per cluster and there are 10 clusters. This looks like a random sample of individuals, so there's no structure by cluster. So you see that this is all related to what outcomes look like. Here we're talking about an outcome that is distressed versus not distressed. It's binary rather than being on a scale. So that's clustering of outcome. So we need to account for the clustering of outcomes that we anticipate will arise in a cluster randomized trial when we've randomized clusters. So in our group PM plus example, that was randomizing wards of individuals. So let's do another thought experiment for about 5 minutes. And then when we've talked about analysis, we'll move back into design. So another thought experiment here. So imagine we have 2 cluster randomized trials that are inspired in a way by group PM plus, but they're different in some key ways. So imagine now, instead of 72 wards, we have 10 wards in total in each of 2 trials. So each of 2 cluster randomized trials, so CRTs. And we're going to have 5 intervention wards and 5 control wards in each of the 2 trials. And there will be 100 participants per ward. So it will be 500 in the intervention wards, and there'll be 500 participants in the control wards. Now, you might think, why are you changing from the size of these clusters? Part of the reason is so that if we want to look at the details of the statistics, it's easier to show you those details in this slightly bigger setting. So I'd be happy to talk about that at the end. So now we have 500 individuals in intervention, 100 in each of 5 wards, and 500 in the control arm, 100 people in each of 5 wards to make 1,000 participants per trial, and there's going to be 2 trials. And I'm still going to talk about this kind of binary outcome, which is distress at the 20-week follow-up. So in the previous slides, we were just imagining we only were observing people in the absence of intervention. Now we're going to be contrasting between wards that received group PM plus and wards that did not receive group PM plus. 5 received group PM plus, 5 did not. So all the following slides will have the same following structure. So what I'm showing here is, imagine this is going to be a summary of outcome data for one of the trials. And here will be the summary of the data for the second trial. And these ones here in blue, these are outcome proportions in control, the control clusters. And here are outcome proportions in intervention clusters. So what do I mean? So here we have the ward level proportion. So out of the 100 people in each of 5 wards that were randomized to control in this trial A, here we see the proportion with distress at the 20-week follow-up. So it varies around 10%. It goes from 14, 12, 10, 8, and 6. Let me actually see. Sorry, 12, 11, 10, 9, and 8. Let me be a bit more precise. And here in the intervention wards in this trial A, we have outcome proportions in the 5 wards of 8% had this distress at 20 weeks, 7, 6, 5, and 4. In contrast, so remember this summary right here is 100 people in the ward. Of the 100 people, 12% of them are experiencing distress. So you see kind of overall, there's these higher proportion in trial A. We see overall each ward in control still has a higher proportion with distress at the 20-week follow-up, down to this one, which is 8%. And the highest level in this trial here is 8% going down to 8.7654%. In contrast, you see a lot more between cluster variability over here in trial B. So we talked about this between cluster variability. So you see it ranging now, it's centered on 10%, but we have a trial up here with 16. This is 14, 10, 8, and 4%. And here we have the values over here in intervention. We have some overlap in that. Outcome proportions at the ward level, the proportion with distress at the 20-week follow-up. So what do we see? We've said already we had 5 wards, each randomized to control and intervention, and 100 eligible participants in each ward. So there'd be multiple group PM plus groups being delivered in these intervention wards right here. And then overall, in each of the trials, overall, out of the 500 people in control, and then separately, there are 500 people in intervention. Remember, these bars I'm showing you are the outcome proportions in each of the wards, but they come themselves based on 100 people per ward. So overall, there's 500 people. Out of 500 people, there's 10% who experience distress at the 20-week follow-up in control, versus 6% who experience overall who experience distress in intervention at the follow-up, a 20-week follow-up time point. And that's the same in control and intervention in the 2 trials. But what we see is a very different pattern of clustering between the 2 trials. So my question now to you would be, imagine which trial do you think shows more evidence of benefit? So you might just reflect on that for a moment. And probably as you're reflecting, you think, well, there's a lot more noise in this trial over here. And in this trial, the trial A, there's a lot more separation of the outcomes, the ward level proportions with distress at the 20-week follow-up. And you'd be right there. So we have lower between ward variability, so less clustering in trial A, and little overlap of the green and blue, so of the outcome proportions between intervention and control. But we have a lot more overlap over here. There's a lot more noise, there's a lot more to disentangle, there's less signal relative to the noise in trial B. So even though both of these trials have the same overall proportion in control of 10%, who experience distress at 20-week follow-up versus 6% who experience distress at 20-week follow-up in intervention. So the overall summaries are the same in the two trials. The conclusions from the two trials should be expected to be rather different. Okay, so if you know what a p-value is, I'm going to briefly mention these. If you don't know what a p-value is, let's just use it as a measure that can help us determine whether or not the evidence supporting a claim of different effect of the group PM plus intervention, whether or not that is a meaningful claim. And what we're looking for is smaller values are more supportive of a claim that there's evidence of benefit of the group PM plus intervention. So for those of you who do know p-values, this will mean a little more for you. So I'm going to still try and do this intuitively. So it so happens that if we ignore the clustering in the two trials, we would just be comparing these two proportions, exactly the same comparison in the two trials. And it so happens then this metric, this value called a p-value, is calculated as 0.02 for both trials. And in traditional kind of medical research, this would be considered to be a meaningful support for a claim that group PM plus is having a benefit in terms of having a lower proportion with psychological distress at the 20-week follow-up. Now, it so happens in trial B, when we perform a statistical analysis about which I won't share details right now, but when we account for the fact that actually we have this variability in outcome proportions by ward, so clustering of outcomes, that we have a much larger value, this one in red here, of 0.22. And in general, most people would consider that this p-value does not provide enough support to make a claim that group PM plus in trial B has a benefit on having a lower proportion with psychological distress at 20-week follow-up. In contrast, in trial A, when we perform an appropriate statistical analysis, so this is a cluster level analysis, we do additionally have this rather small p-value of 0.02, which would tend to, in most medical circles, be considered to be supportive of a claim that this 6% outcome proportion of psychological distress at the 20-week follow-up in intervention in the group PM plus arm is really good evidence that we have a reduction in psychological distress as a result of group PM plus. So lower proportion with psychological distress at the 20-week follow-up. So this 6% versus 10%. Now, there's a whole other question as to whether or not you consider that difference in proportions to be meaningful for you, but we'll put that question aside for now. Here we're talking about that's an incredibly important question, but from a statistical perspective, we're using this to get insight into the implications of accounting for clustering in analysis. So I can come back to this at the end if people would like more details of what the test was that I actually performed. So we'll move on for now. So very different conclusions if you look at these two different trials. So we analyzed this using a cluster level analysis. The overall sample size of the number of wards in each of the two trials was 10, but the effective sample size was very different. Both trials had the same signal. It was that 10% psychological distress in the control arm versus 6% with psychological distress at 20-week follow-up in the intervention arm. But we have very different conclusions from each trial when we appropriately account for clustering of outcomes in the analysis of each of those two trials. And we had lower between cluster variability, lower clustering in that trial A, the one on the left of the screen here, than in trial B. And then accompanying that, we also had a smaller p-value for those of you who know p-values in trial A than in trial B. So the key message here, this was one of the messages in that very first slide I had, is if we must account for clustering when we perform analysis. So the cluster design must be accounted for in the analysis. And what we saw here was if we incorrectly ignore the clustered design, we could claim that a trial is significant or has a meaningful evidence of a meaningful benefit when in fact it isn't. That was the case of trial B. Now, in practice, we often use regression approaches for those of you who know about individual level regression, more so than cluster level analysis. So we'd be analyzing data from all of the 1,000 participants in the trial rather than those 10 ward or cluster level proportions. And we often, for those of you who know these methods, would use things like generalized linear mixed effects models, generalized estimating equations, so GEE. And we had a review in 2017 of many of the methods, and there are other reviews available of those kinds of methods. Okay, so I know we have a few minutes now. So I'll just give a flavor of a series of designs. And Ritika and Binita, Drishti, you'll let me know if you'd like me to just pause here, if you'd like me to not just take a few more moments on this. So don't hesitate to unmute and I'll keep going. Okay. So in all of this, we've just talked about the analysis and how we have to account for clustering when we analyze cluster randomized trials. I also said, if you can, please do an individually, like a regular randomized control trial. So you might say, well, why on earth do you randomize clusters? So let's think about the group PM plus example. And the reason you might say that is, well, you have a lower effective sample size. You have to use more complicated statistical methods. The design can be more complex. So imagine we had tried to deliver both group PM measure within the same ward, individuals receiving group PM plus and individuals who didn't receive group PM plus. In practice, you'd actually hope individuals who receive group PM plus would share information about the intervention with other members of their ward. So if we were to study within the same ward, individuals in both group PM plus and control, we'd have this potential contamination. So in practice, in real life, we probably actually would like this kind of spillover of effects. But when we're trying to evaluate this from a scientific perspective, we want to minimize this kind of contamination. So we took wards that were geographically distinct from each other so that we wouldn't have this sharing of knowledge from those in group PM plus to those in the enhanced usual care arm of the trial, so the control arm of the trial. Also, we might have an intervention that targets clusters. So it might be a program, say, to increase diagnostic capacity of a healthcare facility. So then we really do need to randomize healthcare facilities there, the clusters in that kind of trial. And in some instances, it can be logistically easier to implement randomization by cluster, and the benefits of the logistics and implementation may far outweigh the downsides from the statistical perspective of this clustering of outcomes. So another thought experiment in these last couple of slides. So imagine now we had 8 wards, 8 clusters. So there were 4 had been randomized to intervention and 4 to control. So you can imagine this green being the group PM plus and the blue here being control. And suppose it was a 1-year intervention and group PM plus actually went over a whole year, for example, just as a thought experiment. So what we've been talking about just now and with the 72 wards in group PM plus is called a parallel design. We took the 72 wards, randomized them half-half to intervention and control, and we followed the individuals in those who'd been enrolled in those wards. We followed them over time. So we had 2 follow-up time points. In this visualization, suppose we had 1 follow-up time point. So a standard parallel design would just take 1 follow-up measurement and might not have baseline. But we could also take baseline measurements on everybody, which we did in group PM plus, and those would all be observed under the control condition. So that's one visualization in this simple example of 8 wards, so 8 clusters. Now imagine we could turn on group PM plus and turn it off. We know in practice that should not be possible, but imagine that we could. Imagine we had something like a hand washing protocol with special hand washing disinfectant. Let's say it's that. The intervention is giving clinics hand washing a special kind of hand washing disinfectant. Well, we could randomize 8 clinics, half of them to receive that immediately, and then in the second year to no longer have access to that kind of hand washing sanitizer, but a different one. And the different one would be the control arm. And then we could have half of them, first of all, didn't receive that new hand washing sanitizer. And in the second year of the study, they did receive it. This is a crossover design. The clusters cross over. In half of them in this example go from intervention in first year to control in the second year, and half go from control to intervention from the first to second year. And maybe or maybe not, we have control measurements on all of those clusters in the first year of the study. That may or may not be the case. Now, alternatively, we might have those 8 clusters all start in the control condition, and over a longer period of time, every year, 2 of them switch over to receive this new hand washing sanitizer, and they keep it for the duration of the study. So you see down this image right here, I think I didn't put the visual here. Hopefully you can see my mouse, this step coming right down here. So this stepped wedge design is a one-way crossover design. You see we only go from blue to green, not green to blue, as we did in the crossover design. And this is also called a complete stepped wedge design because every cluster is observed in every period of this study. So these 5 years of the study, the baseline year, and then follow-up years 1, 2, 3, and 4. We might also have a situation where we don't have measurements on all clusters in all time periods, and that here is an example of an incomplete stepped wedge design. We may also consider that this is not really quite like having the full intervention. It's more considered a maintenance period, and we might want to estimate what the intervention effect is during this maintenance period of orange, maybe when there's not this strong support for supporting people to use in our example of the special hand sanitizer. Now it's routine practice, is that able to be maintained? So in practice, the crossover so this design versus the parallel design might help you get more statistical power if you're able to do that kind of design, because the clusters receive both intervention and control. So all clusters receive intervention and control, but this only works if you're able to switch off an intervention and there's no carryover effect. So this really would not be expected to work in the group PM plus setting. Now, the stepped wedge design, again, every cluster gets control and intervention, but now the design has confounding of intervention with time. And why does that happen? It's because on average, the intervention, so that new hand sanitizer, is rolled out later in calendar time than the control condition is. So this you should only really choose when it's not appropriate to do a parallel cluster randomized trial design. These are very popular these days, but you have to be very cautious about designing these. And our recommendation is try to avoid doing a stepped wedge design unless it's really the best choice for your setting. So in summary, ideally do an individually randomized controlled trial, if you can, if there's no intervention contamination and the intervention isn't targeted at the group or the cluster. But we do have that situation in group PM plus. So then we did in group PM plus this parallel arm cluster randomized trial. 36 were in control and 36 were in group PM plus. So that was a very natural design for us. The crossover cluster randomized trial would have been a great one. Were we able to switch on and off group PM plus? And there were no carryover effects of group PM plus over time. And then the step wedge cluster randomized trial, imagine that we had this hand sanitizer, new hand sanitizer being rolled out to health facilities. Well, in that case, it's going to be rolled out everywhere, but at least if we're able to randomize the start time at which it's rolled out, we have a randomized evaluation that can help us try to evaluate the impact of this new hand sanitizer being used in practice in health facilities. But we really need to hope that external events don't really influence the outcomes of interest in the trial, because we're already concerned about this potential confounding of time with the intervention rollout in the step wedge design. Okay, so we have lots of challenges. Which cluster should we choose when we randomize in cluster randomized trial? Hospital, ward, physician. When there are few clusters available, as I mentioned, and we randomize those clusters, there's still potential confounding. So we don't necessarily break the relationship between potential confounders and those individuals who receive the intervention as a result of their cluster being randomized to intervention. There are could be multiple layers of nesting, so you might need complex methods for simulating sample size calculations. There might be difficulty in obtaining good estimates of clustering when we need to design and plan the cluster randomized trial. And there might be selection bias if the participants are not blinded and participant recruitment occurs after randomization. That was a fear of ours in the case of Group PM+. So we had lots of measures in place to try to avoid selection bias because we recruited the participants after the wards had been randomized. So we have a series of reviews that are available. I happen to show the ones that I've been fortunate to have been involved with, and there are many other good ones out there. So this is a bit of shameless advertising on my part. So in summary, this is what we said at the beginning. Cluster randomized trials are trials in which groups, so clusters of individuals are randomized. They're very useful to evaluate effectiveness and implementation measures of group-based and facility-based interventions. This clustering of outcomes leads to lower effective sample size than our standard individually randomized controlled trial. If we were to have the same number of individuals in the cluster randomized trial, our sample size would be, effective sample size is lower. So the information we have would be lower than had we been able to do a randomized controlled trial. But as I mentioned, there's many situations where we need to do a cluster randomized trial. And this outcome clustering must be accounted for in design and analysis using special statistical methods. And as we just saw there, I gave a few examples of lots of different CRTs, so cluster randomized trial designs. But again, to reiterate, if it is possible to perform a regular randomized controlled trial, please go ahead and do that rather than going with the cluster randomized trial. But if you do go ahead with a cluster randomized controlled trial, then there are many of us in the world these days who really love and thrive on designing and analyzing these kinds of trials and really enjoy partnering on ensuring that they are done in the best way possible. So thank you so much for your attention. I think I don't know if you'd like me to stop sharing the screen, Drishti, Binita, Ritika. Would that be helpful at this stage? I imagine. Should I stop?
That's fine, Liz. And
Okay.
it was really impressive presentation. Like, I love how you incorporate all the information, huge information in a single presentations. I think it was really helpful for the participants as well. So everyone, now we will be having 10 minutes of question and answer sessions. Like, if you have any questions, you can write down in the comment box, message box, and also raise your hand using the Zoom app. So we already have some questions from Dr. Dhirendra, I guess. So I think I would like to split the questions. So the first questions here, Liz, is what is the benefit of cluster randomization instead of simple randomization or block randomization?
Okay. Thank you so much for the question. So block randomization can actually be used in cluster randomized trials. So let me try to think of two different ways of saying this. So maybe let me start with the cluster randomization versus the individual, just the principles of it. So now, as you've seen through this, hopefully through the talk, the benefits of cluster randomization really are that it's a design. If you perform a cluster randomized trial design, like you perform a cluster randomized trial, and that's your chosen design, and you've just determined that's the best design for a given situation, then if you have, actually, maybe let me just say this in a different order. If you have a research question, such as the example I was talking about, if you are going to introduce a new hand sanitizer to a health facility and try to get every member of the health facility to use that hand sanitizer, and it's a protocol for the health facility, say the ministry is bringing in that protocol, and it's going to be implemented within an entire health facility, that's a situation where the intervention is at the cluster level. Maybe this is the easiest way to start answering this, is at the cluster level, at the health facility level. So in fact, in that given setting, it would be inappropriate to perform individual level randomization, because the scientific question is, when we introduce a protocol and this new hand sanitizer to kind of improve hygiene within health facilities, how does that work at kind of a health facility level? So that's then considered a kind of cluster or health facility level intervention. And in that instance, that's kind of maybe this is a good way to hopefully address your question. That's a stark example of where it would actually be inappropriate to perform individual level randomization, because the research question is about the kind of health facility level impact of this whole program and protocol. And so in that case, it's a stark example of why the cluster randomization is needed. And then in that case, it's beneficial and appealing because it's actually the only kind of appropriate design is to use some kind of cluster randomization in that kind of setting. So in my mind, the kind of benefits of cluster randomization are really linked to the type of research questions that we can address using designs that randomize clusters of individuals. So I hope that's kind of touched on, and I'll just mention something about the block randomization, and whoever asked the question, please let me know if you'd like me to elaborate a little more. But block randomization can also be used in cluster randomized trial design. For example, if we are going to perform we want to promote some kind of balance on certain characteristics of the clusters, we may organize our 72 clusters into blocks and perform the randomization with these permuted blocks of the 72 clusters. We didn't use that kind of randomization of the 72 wards. So the 72 clusters in the group PM plus trial, we used a slightly different approach, but it had a similar flavor to block randomization. Also, what is one other point, everyone, sorry, I know I'm thinking lots of things that are related to this. Block randomization is often of great use in individually randomized trials when we're recruiting the participants sequentially, maybe I shouldn't use that word sequentially, but we're recruiting them over time. In many cluster randomized trials, we have all of the clusters at the same time. They're all enrolled at the same time. So in Group PM Plus, we have the full list of 72 wards, and we perform the randomization in one go. And so we also had that particular feature that worked in our favor for the kind of options we had for how we were to perform the randomization of the wards in that kind of example. So I hope, please do unmute or post. And I actually now can't retrieve the chat. The chat's disappeared on my two screens. Sorry, everyone.
Okay.
I can't see the
Liz.
chat right now. So I don't know if that has answered the question. I hope that has at least partly answered the question.
That's fine,
Yeah.
Liz. Let's move towards the next questions.
Mm-hmm.
What are common ways of estimating or evaluating clustering when evaluating mental health interventions?
Please do feel free to unmute the person who's asked this question. So maybe I actually have a couple more slides that actually would be useful. So if you permit me, I'll just show you these slides. And I hope this is going to be a response to the flavor of your question. So the types of measures, I think, was that the question, Binit? The type of measures or the types of ways in which we can measure clustering? Is that, I still don't know where the chat has gone.
Yeah,
Yeah. Okay. So there is a measure that is very, very commonly used to quantify, so measure clustering of outcomes in cluster randomized trials. So we'll come back to these slides. So I have the same 3 slides, but I also have some information on a measure. So I think let's take 2 minutes to take a look at this because it's a very important measure that's used commonly in trials, and I hope this will address the question. And again, please do unmute or let me know if I can say anything else to help cover it. So you may remember here, sorry I had that typo on, so typographical error on the slides. I'll correct it and resend it out again. So you may remember we talked about this being a situation, at this point, there's no intervention versus control comparison because it's important to look at these measures of clustering in the absence of intervention, so the absence of differences between or potential differences between arms. So you might remember I said, imagine this, we had 10 wards and each of them had 5 people. So the larger circles, shapes are ovals, are wards, and there are 5 people in each of those wards. Excuse me. So in total, there are 50 people, not the 100 that we'll have on the next slide. So there are 10 wards and 50 people, 10 times 5. And in this instance, this is a case of complete clustering. So the effective sample size is 10 because within a given cluster, everybody has the same outcome. So here, everybody's red, everybody's not distressed. But in this other cluster, this other ward over here, every one of the 5 people, so 100% of the people, 5 out of 5 are distressed. So in the very common measure, so coming back to the question, the measure that's most commonly used is the intra-cluster correlation coefficient, referred to as ICC, and it's often denoted or use this symbol rho, the Greek letter rho. Many people use that to kind of as a symbol to represent this measure. So in this case, how is it defined? So it's defined as a measure of the between cluster outcome variance. So how different are the outcome proportions between the clusters, the outcome proportions, the outcome who are distressed, the proportion distressed, and then it's all relative to the total variance. And the total variance kind of in the system, so this total variance of distress, this binary measure being distressed or not, this is the sum of the between cluster variance and the within cluster variance. So the within, this, hopefully people can see this blue, this comes from this within here, which is 0, because none of the clusters have any variability within the clusters. But between the clusters, some clusters have 100% who are distressed and some clusters have 0% who are distressed. So in this case, this ICC, intra-cluster correlation coefficient, this measure of outcome clustering, in this context where there isn't even an intervention at play, we're just looking at structure by these 10 clusters, these 10 wards, this is equal to 1. So this is considered complete clustering. The effective sample size is 10, like having 10 people effectively, not having 50 people in this visual here, because there's complete clustering. Okay, now we saw this intermediate kind of setting where we still have, we can define this measure, this ICC as well. So in this case, there are differences between clusters because there's different proportions who are distressed. So there are different fractions of purple between different clusters, and there's now some within cluster variation in nearly all of the clusters. So overall, we do expect this sigma squared B to be between 0 and 1, and we also expect the sigma squared W to be between 0 and 1, so the within cluster variation to be between 0 and 1. So that means this value here, this ICC, this measure of outcome clustering, and the outcome is being distressed, yes, no. This value then itself goes by mathematics goes between 0 and 1, and this is a measure of some degree of clustering. Now in practice, most cluster randomized trials are in most settings with clustering, even if you ignore intervention, you expect to have pretty small numbers for this ICC, like the value is often below 0.05. And you might think, oh, a value of 0.05, that seems so small. Why would that even matter when you're going to design a cluster randomized trial? Well, in fact, it really does matter, even if you have a pretty small number for this ICC, this intra-cluster correlation coefficient. And let's just go to the last one. So sorry, I'm going to correct this. This should say the effective sample size is between 10 and 50, not 10 and 100. I'm so sorry about that. And here we have another 50 people, but in this situation, there's no outcome clustering because there is no structure according to the wards. All the wards look exactly the same as each other. They have exactly 1 out of 5 people who are distressed. So let's see what that means for these variance components. So there is there's no between cluster variability because they all look the same. There is some within cluster variability, but because of the way this is defined, how large is the between cluster variability relative to the total? So there's no between cluster variability. So therefore, this measure of outcome clustering of this measure of just being distressed or not, this ICC is equal to 0 in this case. So I hope that responds to the question as an example of how it's measured and a bit more how it's defined, I guess I've responded to, but hopefully that covers it. And then we have statistical methods we can use when we have a data set in front of us to actually obtain this kind of measure of, for example, the ICC for a given setting or a given cluster randomized trial. Yeah.
Okay, thank you, Liz. I apologize to everyone. We have time limitations and cannot address all the questions. You can email us to our email address for any kind of information you need after that. So, Liz, can you share your summary slides or summary statement, something? Yeah,
I can. So I was going to maybe just say them, but maybe I will come back to this because this is really, I think, the key. I know. Thank you, everyone, for your wonderful questions. What I'll do is take a look at the other questions and see if I can write out any responses and we can send those round to you. And please don't hesitate to reach out if you'd like to ask some more. I recently had a baby, so I'm a bit slower at responding to email these days. So please forgive me in advance. But in summary, we've seen there are situations, even though I've said, the last one down here, please don't perform a cluster randomized trial if you don't have to. I spend my life doing them. I love them, and we do them when we really need to. And when we really need to, we have to recognize the fact that there's clustering of outcomes. We can use them to address really important questions. Look at Group PM+, it informed the protocolization and development of a manual by the WHO of the Group PM+ program. But we know we have this, as we've just seen again in that last slide, this lower effective sample size when we've performed cluster randomization rather than individual level randomization. So you can work with statisticians like me. Many of you on the call may be statisticians too and have this expertise. And I hope at some point I can connect with many of you on different endpoints. And I do hope to visit Nepal again sometime very soon in the future. So thank you so much. Have a lovely evening, everybody. And yeah, good night.
Yeah, thank you so much, Liz. It was such an informative information, and I think it was really helpful for everyone as well, for early career researchers as well, because you have mentioned so many information, huge informations, and we are really grateful having you in this webinar. And looking forward for more collaboration in future as well. Thank you so much everyone for joining us. And as I already mentioned, please do email us in our amateur and email address if you have any kind of queries related to the webinar. We can connect you with the speaker as well, or we can reply with more information which you need to, of course. And thank you so much, Ritika ma'am and Justri ma'am, for your support and presence here in the webinar. And see you in the next webinar. Thank you so much, everyone. Bye.
Thank you,
Goodbye.
everyone. Thank you so much.